Thank you and good afternoon. Thank you, Adrian, and thank you, Ruben and Mort, for giving me the opportunity to speak on one of my favorite topics, transplant, or why not to do them. And I changed the title of my talk a little bit. You can see it said, one size fits all. Should everyone, put the edit, anyone eligible get upfront autologous stem cell transplant? So first of all, the number of choices are growing astronomically for myeloma. There are more new combinations involving already approved drugs. There are clinical trials of drugs recently and not yet approved. There's a slew of new drugs and new drug classes that we ourselves are working on with activity in myeloma. So it's very clear there are a lot more options for myeloma today. And I think it's imperative that patients with an incurative disease be able to avail themselves of the opportunity to receive these new smorgasbord of treatments. Reducing that ability with too much prior treatment that's detrimental in the long run is a bad thing to do. So what the patient really wants, not necessarily the professor, but the patient wants the longest life. And that's overall survival, not simply a delay in disease returning, and I can certainly talk about delays, having gotten a 4-hour delay on Virgin from LA yesterday, with possibilities that lead to a patient having the least impact, not only from the disease, but from the therapy. We often forget this message. It doesn't necessarily mean they want a CR, and remember the CRs are in fact, a lot of these are paraprotein based. They're not really molecular CRs, and even the MRD CRs aren't really CRs, as I know. We did a lot of work on this and a lot of the early work in transplanted patients with stem cell selection, and I can tell you there's a lot of difference in sensitivities. It's very hard to do these assays. So what are the arguments for transplant in myeloma? Highest CR rates, higher CRs are associated with a delay in time to progression, prolonged progression-free survival. We just saw that in the talks. Some of the older randomized trials of transplant versus no transplant, again, showed better PFS, delayed time to progression, and in some cases, an overall survival advantage. And then, of course, people have argued, you get a treatment-free interval, you're done. There's no additional therapy required following the high-dose therapy procedure. So let's talk about the first argument. Higher CR rates and higher CR rates are associated with the delay in time to progression and prolonged PFS. So again, as you've heard, we are seeing astronomically high CR rates without a transplant from several years ago from the KRD frontline data, and even more astounding data with some of the recent 4-drug regimens as well. So the argument that higher CR rates are occurring with transplant kind of goes out the window. But I think more imperative is the data you've just heard about showing that patients who have CRs have delays in progression every time in these trials. Well, these, first of all, are not truly CRs. These are based on M protein becoming undetectable, and even the molecular assays and flow cytometric-based CRs, they're only as sensitive to the assays. They don't provide true basis for cure. Really importantly, why do CR rates consistently delay time to progression? Well, you can see it in the bottom half of the slide. So indeed, if you're patient 3 with measurable paraprotein, I can measure progression immediately. But what about patients who have levels of disease below detectability? That is patients 1 and 2 here. They're not cured, they're progressing. I can't measure it. So no matter the trial, if your CR rate's higher in one arm than the other, you're always going to have a better time to progression. That doesn't necessarily mean anything in terms of a clinical endpoint unless you can equally measure progression in every patient on a trial. And we can't do that now, unfortunately. Secondly, older randomized trials showed, again, sometimes an overall survival advantage, and consistently for reasons I just gave you, a delay in progression and progression-free survival advantage. So, however, there's really even no consistently in overall survival for randomized phase 3 trials, even in the days we had inferior therapy. Yes, the older French trial, the MRC Great Britain trial showed improvement of transplant versus no transplant. However, the Piedmont trial did not show this. Every meta-analysis shows the same thing. PFS, yes. Overall survival advantage, no. And what about early versus late transplant? Well, you know the story. The French trial for Vermont, no difference in overall survival. The 93-21 SWOG trial that I was part of, that Dr. Barloghi led, no difference in overall survival. And then more recently, a retrospective study from the group led by Dr. Kumar at Mayo Clinic, and those patients who had thalidomide or lenalidomide with Dex up front, and either had an early or late transplant, either before or after 1 year. There's no difference not only in overall survival, there's actually no difference in progression-free survival either. Now, what about with the newer drugs, the Imedex drugs and the proteasome inhibitors? Well, this is data from Dr. Palumbo, published in the New England Journal of Medicine. 402 patients with symptomatic myeloma who'd seen 4 courses Len-Dex were randomized to melphalan, prednisone, or Len, or actually 2 doses of high-dose therapy followed by stem cell transplant, and either maintenance with lenalidomide as a single agent at 10, 21 on, 7 off, or no maintenance. And although on the left-hand side, there's clearly a difference in progression-free survival between the arms from diagnosis, there's actually no difference in overall survival. Yes, if you combine arms, you can certainly make the data show, as he did, that the transplanted patients did better, but if you look at the 4-arm singling, as you should in a clinical trial, there's no difference in overall survival. Now let's move on to the trial you just heard about, and that is the French trial. 700 patients, all randomized after 3 courses of RVD to either have 5 additional courses of RVD or high-dose MEL and 2 cycles of RVD, and everybody got maintenance therapy 3 weeks after finishing consolidation with 10 milligrams of Len. So what did we see? We just saw it. Yeah, we have a great progression-free survival advantage for reasons I would agree. You're going to see that because you can't measure the relapses. But guess what? There's no overall survival difference. It's a consistent theme here. There's no difference in how long the patient lives, whether they have a transplant or not. Indeed, there is a difference in the survival based on MRD, remembering that MRD is not really cure. It's based on an assay with a certain sensitivity level. So what is that? What are we saying here? Well, we're telling you that MRD negativity was certainly higher proportion in the transplanted group, 79 versus 65%. But they also included patients with VGPR. Those patients certainly don't have MRD business being measured in my view. But again, there's no difference in overall survival between the transplant and the RVD alone arms. And remember, as my old colleague and my mentor, Dr. Haskell, said, you have to be careful because your endpoint may have nothing to do with your therapy. Indeed, MRD negativity may be a surrogate for patients doing well and not necessarily related to the treatment at all. To suggest that transplants are necessary because more patients achieve MRD is a false assumption because overall the transplanted group, they didn't live any longer than RVD alone group. And what about the side effects? Certainly observed, there was 3 times the number of deaths, there were 4 AMLs and only 1 in the RVD alone. The grade 3 and 4 adverse events were significantly higher. Cytopenias, neutropenia doubled, and of course, febrile neutropenia tripled, thrombocytopenia way higher, infectious rates more than doubled, sepsis 3 times the rate, and of course, GI higher, specifically stomatitis. And that's the short term. What about the long-term effects of transplant on the patient and their ability to receive more therapy? We don't have that from the trial. Okay, what about no additional therapy required following the transplant? Well, you and I, that went out the window now with the maintenance data from both the US and the French trials leading to FDA approval of maintenance lenalidomide at 10 continuously. 2 trials, both placebo-controlled, double-blind, patients undergoing transplant and then randomized to either receive Len at 10 or no maintenance. And we know the story. Of course, in the study 1 from the US, an improvement in overall survival from 7 to 9.3 years. The European study that didn't go quite as long in terms of the maintenance, showing a 7.3 to 8.8 year overall survival advantage, but leading to FDA approval. So again, there isn't any more a treatment-free interval after high-dose therapy. That argument is gone. So transplants in 2017 for myeloma, there is no overall survival advantage of early autotransplant from any recently randomized trials, including those with the new drugs, the IMiDs, and the proteasome inhibitors. The highest CR rates are now seen even without transplant. And all patients today are receiving maintenance treatment with lenalidomide with or without a transplant, so there isn't any treatment-free interval advantage anymore. And the treatment options are rapidly increasing. So to compromise a patient's ability to receive these new options because of the long-term toxicity from high-dose therapy is important to consider. And you have to be very careful about interpreting results from parts of the world in which treatment options are limited. They may have no relevance in a clinic where there are many options that may not be available in some of the other parts of the world, which may lead to an advantage you may be able to see with a transplant. I haven't even seen it from the trials recently published, however. And as patients are living so long, many of my patients, 20, 25 years, they care a lot more about quality of life than they did in the early days when they were hanging on for dear life to just stay alive. That's not true anymore. They care a lot about quality of life. So summarizing, it's not about more, it's about more specific, as my wife's acting coach says about her on stage. And transplants are only about more. It's time to be more specific. The beginning of this saga, of course, is the monoclonal antibodies, but we got a lot more work to do. These are more tumor-specific treatments. And with so many options today, our therapy should be tailored to each myeloma patient's disease, comorbidities, and lifestyles. So my belief is that transplant should not be an upfront option for myeloma in 2017 until we can clearly show a benefit on overall survival. Thank you.